Hello, everyone. A warm welcome to all of you and a very good morning. So, today is our second day of this Puji developmental program. Uh, I hope that you all had a comfortable stay here. So, our session would be starting with Dr. P.K. Joel, sir. He is a retired professor in HOD of Jabalpur Medical College, and he has a clinical experience and teaching experience of more than 40 years with many national and international publication. And we are very glad that he came here to enlighten us with all his knowledge, and hopefully we all it will be very beneficial for all of us. Thank you, sir, for coming, and a very warm welcome to you. So, sir, today we'll be speaking on the topic of ethical issues in psychiatry. So, welcome you, sir.
Hello? Okay. Thank you. Good morning, everybody. Welcome. Today, I am going to speak on a topic which is not a topic. It is something lying in a gray area, and that is ethical issues in psychiatry. What are ethical issues? क्या है ethics? क्या है? पीजीज ethics क्या है? बता दो यार कुछ भी. कछु बोल दो. ऐसा तो लगे सुन रहे हो. What are ethics? Okay, it is a moral code. Right. So, this code is made by us, and it is basically a broad guideline to what all we should do and what all we should not do as a doctor. So, who decides? It's like who decides? Who decides to follow the ethical code? Number one, and who decides to regulate the ethical issues? These two questions you need to answer in medical ethics. Let's forget medical ethics for a time and look at this fact कि क्या है, ये भला क्या है, क्या करना है. तो जो सबसे पहली चीज है, ये एक ऐसी प्रक्रिया है जिसमें हमको भी फायदा हो और मरीज का भी भला हो. इट इज अ म्यूचुअली बेनिफिशियल प्रोग्राम. दूसरा, अगर आपके परिवार में कोई बिजनेसमैन है या आप खुद किसी दुकान पे जाते हो तो उस दुकानदार का एम ये रहता है कि आप उससे वो आपको इतना इम्प्रेस करते, इतना सेटिस्फाई करते कि अगली बार आप उसकी दुकान पे दोबारा जाओ। So it is not only mutually beneficial, but it is also a sales pitch. If I give this person good services as a doctor, not only will this patient come back to me, he will send others too. So, वो हमारी रोजी रोटी, रोजी रोटी का मतलब एक चीज बहुत ही ठंडे दिमाग से बैठ के ये सोच लेना कि they can live without us. We cannot live without them. हमारी रोजी रोटी उनसे आ रही है. Even people who are in government service, even people who are in the medical college or district hospital, you may open a very big department with all the facilities, but if patients are not coming to your department, then सब बेकार. So our aim is patients जो आए. When I started practice in '88 in जबलपुर, तो मैं एक नॉवल लेके जाता था अपने साथ. मरीज आते नहीं थे, बैठ के पढ़ता रहता, पढ़ के घर चला जाता था. ग्रेजुअली एक दो आने लगे, तो 4 हो गए. अब इतने हो गए कि मैं कहता हूँ नहीं भैया इससे ज्यादा नहीं देखेंगे, बाकी जाओ कहीं और दिखा दो. ये रोजी रोटी की आप बेइज्जती नहीं कर सकते. यू कैन नॉट डिसरिस्पेक्ट देम. एथिकल इश्यूज में जो एथिक्स में सबसे पहली चीज जो दी गई है इज बेनिफिशियल, टू बेनिफिट, मरीज का भला करना. और इसी के ऊपर बाकी सारे एथिक्स के रिकमेंडेशंस बने हुए हैं. अब इस एथिक्स को रेगुलेट करने के लिए ये 2 वर्ड बहुत जरूरी है जो लाल में लिखे, M&E. M का मतलब me. So the only person who is going to regulate these ethical issues is you. ये आपको निर्धारित करना है कि आप कितना एथिकली बेस्ड हैं ना. उसके लिए आपको 2 चीजें समझनी है. आपकी अपनी वैल्यूज क्या है, आपको आपके परिवार से, आपके समाज से किस तरीके की वैल्यूज मिली हैं. 1, आपने क्या सीखा है, आपके टीचर्स, आपके एनवायरनमेंट ने आपको क्या सिखाया है. और एक चीज याद रखना है कि भैया थोड़ा सा तो कलयुग चल रहा है. तो कलयुग में थोड़े बहुत तो अलाउड हो जाता है. बट एट द एंड ऑफ द डे व्हाटएवर यू आर डूइंग, what you have to remember that it should not be detrimental to your clients, because the day it becomes detrimental to your clients will stop coming to you. And the day they stop coming to you, your entity as a doctor, as a psychiatrist, is gone. तो वहाँ करना है, ठीक है. बिल्कुल ही आप अपन भगवान राम नहीं बन सकते, थोड़ा बहुत करो. पर इतना मत करो कि वो सेल्फ डिस्ट्रक्टिव हो जाए। नेक्स्ट स्लाइड प्लीज। Now, what I have tried to do is कि ethics word को ही हमने थोड़ा सा analyze करने की कोशिश की। The green ones are the positive things that we should need to do, and the red ones are the negative things that we should not do or avoid doing. Empathy, we all know what is empathy, and empathy is the ability to put yourself into the other person's shoes. और ये एक आई थिंक अगर वैसे तो सभी ब्रांच में है, पर साइकेट्री में इसके ऊपर एम्फोसिस बहुत ज्यादा। I think it is the mainstay of psychiatry. Without empathy, you will not be able to see patients properly. Your own experience and your own educational qualification. Now, there is one question which is coming that आप residents हो, अभी first year, second year, so basically you are under trained. आपको अभी training दी जा रही है. You are not a full-fledged psychiatrist at this point of time, but yet in your OPDs, in your departments, you see patients independently, you treat patients independently, but the byline is always there that it is done under the supervision of the consultant of your unit. So now the question comes, if you are treating a patient as a first year resident, should we tell the patient कि भाई देखो, I am a first year resident, okay, and I am treating you. So there are certain limitations. If you want, we can also discuss your case with the consultant in charge, who is more experienced and who is more qualified to look after. This is the ideal situation. This should be done. Patient should be informed about the physician's qualification and capability, because he has come with this thought in his mind that I am going to Dr. Shukla's hospital, and Dr. Shukla is the senior most psychiatrist of Raipur, and I want to show him. When this person goes over there, he is seen by a competent psychiatrist, but not doctor. वो क्या करता है? कहता नहीं, हमें तो बड़े डॉक्टर को दिखा. So then it becomes your obligation कि ठीक है, आप देखिए मरीज, no problem. But then somehow you will convince the patient that yes, डॉक्टर शुक्ला ने भी इनको आपको देख लिया है और डिस्कस कर लिया है हमने उनसे, एंड ही नोज एवरीथिंग अबाउट इट. कुछ बहुत ही जिद्दी होते हैं, नहीं हम तो शुक्ला जी को ही मिलेंगे, तो उनको इनके चेंबर के परिक्रमा कर दी जाए. सेम विथ मी, मेडिकल कॉलेज में ओपीडी में बच्चे मरीज देख रहे हैं, उन्होंने कहा नहीं हमें तो जोएल सर को ही दिखाना है भाई. वो ट्रस्ट आप तोड़ नहीं सकते. You can't make a fool of your patient saying कि ओके उसको दिखवा दो. Is your training, and this information should be given. Now उस तरफ जो है लाल वाला वो सब गड़बड़ वाला exploitation. Exploitation here means जबरदस्ती के इलाज, जबरदस्ती की जांचें, जबरदस्ती के cost increasing procedures. ठीक है, होता है, करते हैं, पर मेरा एक कभी कभी क्या होता है कि जब हम ये सब, एक मैं अपना पर्सनल किस्सा बता रहा हूँ कि मैं छोटे भाई की वाइफ, शी केम जबलपुर और उसको कुछ प्रॉब्लम हुआ। तो मेरे एक फ्रेंड है न्यूरोलॉजिस्ट, उनके पास मैं उनको ले गया। मैंने कहा यार देख लो, कुछ सीजर टाइप है। उन्होंने देखा देखा सब किया, फिर उन्होंने कहा इसका सीटी स्कैन करा। ठीक है भाई, करा देता हूँ। मैं लिख के दे रहा हूँ, खाना जगह चले जाओ, यू आर अ डॉक्टर, फ्री हो जाए, पर करा। मैं क्या करा लाया। बाद में जब खैर she had seizure disorder, she was given medication, she went back to her hometown। फिर मैंने पूछा, मैंने कहा यार तुमने सीटी स्कैन क्यों कराया? एंड ही गेव मी अ वेरी ब्यूटीफुल आंसर। ही सेड देखो यार, हमारी आदत हो गई। अब अगर हम सीटी स्कैन इस मरीज का नहीं करा तो हम कंफर्टेबल नहीं रहते कि हमने ठीक से मरीज देखा। मतलब हमें सीटी स्कैन कराना ही है, तब हमको लगता है कि नहीं, आई एम डन अ गुड जॉब। Otherwise, I am not professionally satisfied that I have done a good job। मैंने कहा यार सीजर डिसऑर्डर का हिस्ट्री से दूर से दिखता था, वो तो इसलिए कि अब घर की मुर्गी दाल बराबर, तो मैंने कहा भाई तुम दवा लिखो। So this was his logic। So sometimes these practices become so part of your treatment that you know। और ऐसे में मरता कौन है? जो गरीब है। अमीर को आता ही है जांच कराने, आप नहीं कराओगे तो वो नाक पर चढ़ेगा, यहाँ तो कुछ नहीं करते। इसकी करा दो, हमें कोनो दिक्कत नहीं। पर जो बंदा अपनी जमीन गिरवी लेके रख के आया है, या जो बंदा महाजन से पैसे उधार लेके आया है, स्पेयर, लेट हिम गो विथ व्हाट इज नीडेड। उसके ऊपर डिपेंड करेगा फिर, है ना? वो सेटिस्फाइड नहीं होगा। एजुकेट हिम, यू डोंट नीड दिस। उसके बाद भी नहीं मानता तो नटल दबा दे, करा दो दो चार सीटी स्कैन। But then we have the duty that we should educate them। So that is what is the exploitation level। Emotional blackmail we all know, and here I think what we are really talking about is sexual harassment, exploitation, relationship, whatever you want to say। It's a big no। You do not, and I repeat, you do not even think, attempt, or try to have any sort of sexual relationship with your patient, even after the treatment has stopped। And not only it should be limited to the patient, but the patient's family also। कई बार होता है मेल पेशेंट है, वो अपनी वाइफ के साथ आता है, वाइफ इज द केयर गिवर, एंड once her patient starts getting well, somewhere in her mind she feels obligated to the doctor that yes, this person has helped my husband, my husband is getting well। और उस फेज में if the doctor is trying to be too sweet towards the caregiver. Now then the caregiver is in a dilemma. If उसके दिमाग में यह है कि अगर वो इस चीज को रेजिस्ट करती है, ब्लॉक करती है, तो this person might stop treating my patient, and my patient is getting better under his treatment. So that sort of pressure, blackmail should not be happening. Not only it is a big no for patients, but also for patients' families. अगला, अगली slide. Okay. Okay. Now the second alphabet is T. I really don't have to explain all this. Truthfulness आपको मेंटेन करनी है, ट्रस्ट आपको मेंटेन करना है, ट्रांसपेरेंसी रखनी है. आजकल ये एक बहुत बड़ा मुद्दा आ गया. हमारे जमाने में, सर के जमाने में ये नहीं होता. ये दवा है, खा ले, ठीक हो जाओ, फिर खत्म, पैसा आ जाओ. अब नया जमाना आ गया, पब्लिक गूगल पढ़ के आती, तो कहती साहब वो ये वाली दवा से तो फला साइड इफेक्ट लिखा है और ये वाली दवा से फला साइड इफेक्ट लिखा है. Then nowadays it has become the duty of the therapist to explain, educate the patient. भाई देखो ये दवा है, इससे ये होगा, इसमें ये खतरा है, and this will improve you in your problem. And then the patient has to accept. We have given the decision making to the patient. You just explain कि साहब ये है, EEG कराने का लॉजिक ये है, CT स्कैन कराने का लॉजिक ये है, ECT लगाने का लॉजिक ये है, और ECT लगाने से ये प्रॉब्लम्स, साइड इफेक्ट्स रिपोर्टेड है. एंड देन उस इंफॉर्मेशन को देने के बाद द पेशेंट इज अलाउड और द केयरगिवर टू टेक अ डिसीजन. हम लोग अभी भी वो नहीं कर रहे, पर आप लोग के लिए अब जमाने धीरे धीरे बदल रहे हैं, तो आप लोग को करना. ऑटोनॉमी बोलते हैं, और इसकी ऑटोनॉमी. थ्रेटनिंग बायस बाय द डॉक्टर, दैट डजंट वर्क. गुंडागर्दी नहीं चलेगी अस्पताल. दोनों आजकल मरीज गुंडागर्दी करते हैं, कभी कभी डॉक्टर करते हैं. So that threat should not. It is a relationship of trust. ठीक है. Sometimes I do threaten my patients, but for their good, not as a negative threat. हम जिनके बच्चे हैं, तो बच्चों को भी बोलते हैं, फिर पिटाई लगाए कि ज्यादा नाटक करो. That is not a threat. It is a threat for the good of the child. But then there are other negative threats which you should not use. Harm reduction is the primary aim of all doctors towards all patients coming to them. अपना पहला और आखिरी एम है कि जो परेशान मरीज हमारे पास आया है उसका उपचार हम करें, और साथ में उस उपचार के माध्यम से उसको उसकी क्रिटिकल सिचुएशन से बाहर निकालें. That is the crux of the matter. ये तो यही अपना अस्तित्व. हार्म रिडक्शन अगर आप नहीं कर रहे हैं तो आप लाख कछु कर लो, what is happening? Then helpfulness, honesty. Honesty is again something which we should try to maintain. कई बार ऐसा होता है कई बार नहीं, मेरे साथ तो हमेशा होता है। आई ऑलवेज रीच माई क्लिनिक लेट, तो माई पेशेंट्स कंप्लेन, अच्छा आज आप फिर लेट आए, आ गया यार क्या करना। But we should not be very upset or angry about their complaint. भाई मेरे क्लिनिक के बाहर लिखा है 6:30 और मैं पहुंचता हूँ 7 बजे, तो they have a right to complain. And it's vice versa. जब मैं 7:45 8 बजे जहाँ खत्म हुए भग जाता हूँ, उठ गया, फिर कोई आया, then I have a right to complain. जब तो दिमाग बंद हो, आधे दिमाग से दिखाना दिखाओ, पैसे पूरे दूंगा। तो वो भी जानता है कि ही इज लेट, देन इट्स हिज चॉइस। कहने का ये मतलब है कि ट्रांसपेरेंसी इस तरीके की होगी। Allow you, I have been managing these patients for years. 20 25 साल वाले हैं मेरे पास, पर you do not allow them the status of a family member. There you have to be careful. At the end of the day, you are the therapist and they are your patients. वो बाउंड्री आपकी नहीं टूटनी। भारत में रहते हो, भारत का कल्चर अलग है। वो आएंगे, वो आपको अपने बेटे की शादी में भी इनविटेशन देके जाएंगे, वो आपको ईद पे भी बुलाएंगे, वो आपको दिवाली पे भी इनवाइट करेंगे, बट देयर शुड बी there should always be a boundary. The moment you convert them into friends or family, you have to stop treating the patient. You have to refer that patient to some other psychiatrist, because now you have become biased. Psychiatrist never treats his family. ये याद, अगर किसी कारणवश he has come too close to you, either you cease the therapy or you push him back. There are patients, many patients who have come to me, who know me in and out, who know my full history. इनके परिवार में ऐसा हुआ, इनके परिवार में वैसा हुआ, सब जानते। Every time they come, first 5 minutes they spend शराब पे, शराब अकेले रहते हैं, आपकी सर्वेंट आ रही, ठीक। Then, but those questions are now all routines. They'll come, they'll ask those 5 questions, and then the consultation starts. Try to maintain that bond. हमारी ब्रांच एक इकलौती ऐसी ब्रांच है जहां हमें थोड़ा सा नुकसान हो जाता है। कार्डियोलॉजिस्ट है, न्यूरोलॉजिस्ट है, अगर वो किसी ऐसे मरीज का इलाज करता है जिसकी शर्ट पैंट का शोरूम है, तो जब वो वहां जाते हैं तो दुकानदार उनको पहचानता भी है, कोल्ड ड्रिंक भी पिलाता है और शर्ट पैंट में 10-15% कंसेशन भी देता है। हम लोग के साथ उल्टा है। एंड यू हैव टू अंडरस्टैंड, आप जब ऐसी कभी दुकान में गलती से चले गए तो अब वो परेशान, अगर वो आपको पहचानता है और नमस्कार करता है तो बाजू वाला उससे पूछेगा, इनको कैसे जानते भैया? सोशल स्टिग्मा, whatever we may say, नहीं होना चाहिए और हटाएंगे और साइको एजुकेट करेंगे, पर जब तक सोशल स्टिग्मा है हमें उसकी कदर करनी। Otherwise, we are putting our clients and their families in a big dilemma. वो पहचानता है तो मरता है, नहीं पहचानता है तो बोलेगा यार डॉक्टर साहब क्या सोचेंगे, इन्होंने हमारे मरीज की इतनी मदद करी और हमने उनको पहचाना तक नहीं। आई हैव हैड अ पेशेंट, मैरिज में गया, एक्चुअली आई हैव ट्रेन्ड माई सेल्फ दैट I made it a rule that I don't wish anyone until unless they wish me. If he acknowledges me, then I wish him. तो वो बेचारा शादी में एकदम से हमने सामना हो गया, उसने he did not recognize me. हम भी अपना नाश्ता पानी करते कर दिए. Next day he came to my clinic and he said, "Sir, I am very sorry." I said, "What for?" बोले कल सर आप शादी में आए थे and I did not wish you. I said, "No big deal. I know." तो कोई ऐसी बात नहीं है, मेरे को बुरा नहीं लगा. This will not affect my treating your patient in any form. But his own guilt was making him feel bad कि यार हमने सर को. तो ये आपको ध्यान रखना. बाकी लोग पूछते हैं आपकी दुकान कहाँ है, इसलिए कि शाम को जाकर निपटा दें. हम हिस्ट्री में ये पूछते हैं आपकी दुकान कहाँ है कि अब भैया उस मोहल्ले में नहीं जाना. So you have to take that into consideration. What are you taking from your patient? Is it unethical? Okay? आगे बढ़ा भाई. Impaired physician के बारे में we talked. जैसे कल शाम को 9 बजे अगर कोई मरीज आ जाता और बोलता कि डॉक्टर जोएल को दिखाना है, तो हम ना करते. क्यों? आज सुबह देख रहे हैं. Yesterday I have taken half a peg of alcohol. Agreed? So once you are intoxicated, even by this much, your judgment is impaired. And if your judgment is impaired, God forbid, अगर उस मरीज को कुछ भी उल्टा सीधा हो गया, you will never be able to forgive yourself for it. Impaired physician means when either he is intoxicated or he is not, either even maybe he is having some psychiatric or physical disorder which is causing some impairment in his judgments. They should avoid seeing these. Okay? देखो वही है कि आजकल हम लोग के पास मोटरसाइकिल होंगे और हेलमेट पहनना कंपलसरी है, तो आप हेलमेट लेके जाते हो और कहाँ टांग देते हो? हैंडल पे. और जब देखा कि कोई चेकिंग हो रही है तो निकाल के, और जैसे चेक पोस्ट के बाहर गए टांग दिया. तो हेलमेट इसलिए नहीं है कि चालान से बचना है, हेलमेट इसलिए है कि जान बचानी. कई एक्सीडेंट आप सुनोगे कि साहब हेलमेट तो था बट इट सेव द मोटरसाइकिल रादर देन द ड्राइवर, क्योंकि वो हैंडल पे टांगा. तो some laws are good, you follow them. They are for your benefit, they are not for चालान. Okay? हाँ भैया, immoral conduct सबसे बड़ा वही भैया सेक्सुअल वायलेशन. एंड सेक्सुअल देखो नॉन सेक्सुअल वायलेशन भी होता है, where it is more at a not at the physical level but at the emotional level. है ना? All these things should be avoided. Cost and barter we talked about. Conflict of interest, ये जैसे भाई अब कोई बिजनेसमैन है, कोई स्टॉक मार्केट वाला, और वो जब भी आता है तो हम उससे पूछते हैं आजकल कौन सा स्टॉक बढ़ रहा है, और उसकी टिप को हम यूज कर रहे हैं अपने इन्वेस्टमेंट्स के अंदर. दैट इज ऑल्सो रॉन्ग. ओके? that is also, you are exploiting your patient's knowledge. You go on a separate platform, take it away from your clinic, and then you can use him as a broker or for tips. That's a different story. You are paying for his expertise. Okay? So using these methods is ethically wrong. Confidentiality पे बहुत बड़ा issue है. Once the patient has told you anything, it remains with you. As I told you, I made it a habit. I don't wish anybody on the street till he wishes me. Because the moment I wish him, confidentiality is breached. क्योंकि मैंने जहाँ विश किया किसी सोशल फंक्शन में ओपी को, तो हर आदमी ओपी से पूछेगा कैसे जानते हो, गड़बड़ है क्या परिवार में? Somebody mentally sick in your family, so you know how to do it. So you have breached. This action is a breach of confidentiality. You're acknowledging your patient or their attendants in a social situation is breach of confidentiality. Confidentiality का इतना महत्व है सर. Make it a habit. My wife always had a complaint. ओपी को बताती, रत्नेश को बताती, हमको ये कुछ नहीं बताते, तुम लोग के सामने सब बात करते हैं, हमें कुछ नहीं बताते. हमने कहा यार अब हमने ऐसी आदत बना ली कि हम कुछ नहीं बताते. कहाँ पे निकल जाए मरीज के बारे में कोई इंफॉर्मेशन नहीं बताते. ये बता देते हैं कि भाई ठीक है, कभी अगर ऐसा है कि अब जबलपुर में बड़ी अच्छी दुकान है, जैसे अनुश्री वाला है, यहाँ से मैं शर्ट से लेता हूँ, तो मैं खुद नहीं जाता, वाइफ को भेज देता था कि भाई जाओ. बट ये आपको कॉन्शियस एफर्ट करना है, consciously till it becomes a habit to preserve the confidentiality of your patient. चाहे उसमें पत्नी नाराज हो जाए, कोई बात नहीं, धीरे धीरे समझ में आ जाता है. नेक्स्ट, कई बार कॉस्ट एंड बार्टर मतलब कई, हमारे जमाने में तो सर के जमाने में जरूर होता होगा, मरीज के पास पैसे नहीं है फीस देने के, अपन भी छोड़ दिया. अगली बार वो एक बोरा मटर ले आया, या एक हमारा सिंहपुर का मरीज था, बढ़िया था, घी लाता था, फीस नहीं, पैसे नहीं थे, लिक्विड कैश नहीं. उसके घर में घी बनता था, जब घी बनता था तो एक डब्बा घी मेरे थे. अब ऐसे के नहीं गलत, अपन मरीज से घी ले रहे और उसको अपन ने बाटर सिस्टम में डाल दिया. भाई ठीक है, हम उससे फीस नहीं लेते, घी ले लो, उतना ही दाम है. कहने का ये मतलब है वो वाटर सिस्टम अब तो खैर बहुत कम हो गया, पर पहले तो बहुत कॉमन था. 2 किलो आलू कोई ले आया, चना भाजी ले आया, हरा मटर ले आया. Those things have now, I think, gradually going away. अब यार अगली, अरे खत्म हो गया क्या? तो इस पूरे प्रेजेंटेशन का बेटा सार यही है कि मॉरलिटी और एथिक्स में क्या अंतर है. एथिक्स टेल्स यू द आइडियल सिचुएशन. आइडियली एक डॉक्टर होने के नाते आपको क्या करना है. मॉरलिटी इज व्हाट इज. जो आज के जमाने में आज के लोगों को देखते हुए, आज के सामाजिक बैकग्राउंड को देखते हुए अपन थोड़ा बहुत एडजस्ट कर लेते करो, एडजस्ट करो, इतना मत करो कि मरीज करो। ठीक है, थैंक यू फॉर लिसनिंग।
Thank you, Dr. Joel, sir, for enlightening and informative lecture about the ethical issues in psychiatry. Hope all the PG residents and everybody here, it was very beneficial for them. It was a wonderful lecture. And if there are any questions regarding ethical issues, you can ask him.
Thank you.
Sir, I have a question. Suppose a patient is suffering from psychosis or depression or whatever, and his caregiver, like immediate family member, wants to know everything, but he has asked you not to disclose it to anyone, even the wife. So, shall we maintain that?
Selective reach हो सकती है, 99% of the time you should only release information when the patient progress. बिना patient के consent के आपको कोई भी information release नहीं करना। मतलब even in the courts they are saying, court is asking for information regarding a patient who is undergoing trial. And the doctor initially has to put in his protest. Wait, according to our listening, we are not. That should be recorded. So here, a caregiver is giving you information, and the caregiver is saying, "Do not release." So the same level of confidentiality
should be maintained. And one more common thing, like after marriage, if the in-laws get to know that she was previously treated for some medical psychiatry condition, they usually come up alone and they ask whether she was here. Okay. And sometimes even they preserve her prescriptions. They
do it. So you call the patient. You talk to the patient for 5 minutes. That you come and ask me whatever you want. That basically you need to take information from
or their parents. Thank you, sir. Thank you. So we proceed to our next session, and the speaker will be online, Dr. Maladevo from Mumbai. He is a consultant psychiatrist in private practice and has got a PG teacher experience of more than 11 years. He is also awarded with Bombay Psychiatry Silver Jubilee Prize and Dr. Anil V. Shah Best Paper Prize. His more than 12 publications, and he's been honorary president of Bombay Psychiatry Society as well as member of IPS course and certification subcommittee. His area of interest are neuroscience and genetics. So he's today going to speak on psychiatry examination of child patients. So welcome, Dr. Maletave.
Good morning, everyone. Am I audible? Am I audible to everyone? Yeah, okay. First of all, thank you for inviting me here to speak on assessment of children. I'll be sharing my screen now. Just let me know whether you are able to see. Is my scene? Just give me a minute. Is my screen visible? Okay, fine. So we'll start without much delay. So I'm going to speak, as I said, on psychiatric assessment of children. And what I'm going to do is, the presentation is roughly in about 3 parts. I'll take some time, a few minutes, to talk about basic neural development in a child. Second, even though my topic is about assessment of children, I have a few slides where I'll give you certain points about assessment of very young children, who we call as infants and toddlers, that is the first few years of life, and then about children. So 3 parts are there. I am going to talk more about the basics of how we assess children, what we need to do in our clinics, rather than specific cases. And I'll take questions at the end. So when we talk about neural development, what do we exactly mean? And first and most important, why am I putting it up here when we are talking about clinical assessment? Let us be very clear about one thing, that psychiatric disorders are present right from day one of life. Nobody develops a psychiatric problem on the day that the patient is got to us for assessment. Now, whether it be an infant, toddler, child, adolescent, or adult, or a geriatric patient, something is happening inside the brains which leads to the development of a disorder. And we need to understand the whole process. What are the determinants of this process? What are the components of this process? We'll get a better understanding of the patient if we pay attention to all these things. The clinical psychiatry is not only about what number of criteria, whether on DSM-5 or ICD-10, are being fulfilled for this patient so that I can give him or her a diagnostic label, and that is going to determine treatment. It is not so. When we see patients, most of the time we are going to see patients, and I mean any patient across any age group, more often than not, having a multiple of psychiatric disturbances. So a patient who has got anxiety, for example, is not only going to have anxiety symptoms. If I ask more clearly and more in details, I am likely to get symptoms of other mood disturbances also, substance use also, and so on and so forth. And sometimes it's going to be a situation where, even though the patient has come to us with anxiety symptoms and the diagnosis is very obvious, still on DSM-5 or ICD-10 or 11, whatever it is, we will have multiple diagnostic labels for this patient. A patient can have more than 3-4 diagnoses also. And so are we going to focus only on one or all of them? And if you're going to focus on all of them, what are the common basic denominators that we need to focus on? So when we pay attention to more background things, the patterns of illnesses become clear. It becomes more clear for us to plan treatment or intervention strategies. And then most important, the question that is asked to all of us, doctor ye kabhi theek ho jayega, ye kitne saal lagega isko treatment, that part becomes more clear and easier for us to explain to our patients and their relatives. So what are the determinants of neural development? One is nature. Why? Because genetics lays the background, the framework for all neural development, whether it is normal or abnormal. So anything going wrong in the genetics is going to have an impact on what is the outcome of that individual, what kind of disorders he or she may have, and how are these disorders going to unfold uh, at different points in time. Of course, nurture or the environment that is given to a child right from day one, and by day one I mean right from conception, not the time after the child is born, This environment, a kind of on the background of genetics, gives a lot of input, good or bad, for the development, neural development, as well as the development of disorders. Epigenesis or epigenetics is also important because many of these environmental influences have an impact on the chromosomes, not necessarily the DNA, but the chromosomes, that is the histones and the end chains of chromosomes, by which, even though if the genes are normal, if the DNA is normal, the kind of proteins that are produced are impaired, are deficient or defective, and then they can lead to disorders as the individual goes along the lifespan. What is important is also the concept of plasticity. All of us learn, we learn right from day one. And the learning happens because the brain is plastic, the brain function is plastic. It's not only the brain that is plastic as a structure, but there are different levels of plasticity. When we keep on doing some things repeatedly, it's not only that there is, let's say, long-term potentiation in the hippocampi, and that is how we learn. That is one kind of plasticity, that is the synaptic plasticity. But with repeated stimulus, with repeated, let's say, practice, what happens is that there are changes at a genetic level also. When there are changes in the genetic level, there is a change in the protein structure and the protein part of the cell. That is also a plastic structure. So plasticity happens at different levels. Another important component is chronobiology or periodicity. That there are certain periods in time where, let's say, the development is happening at a more rapid pace, and there are certain points in time where things are happening at a slower pace. Chronobiology is easy to understand if we consider circadian rhythms. Circadian rhythms means our brain functions, we function on a 24-hour clock. There are certain things that are more predominantly happening in the daytime compared to the nighttime. There is a genetic basis for that. We have what are called as clock genes, period genes, time genes. They decide how our brain and body is going to function on a 24-hour period. So on a 24-hour period, we also have hormonal fluctuations, mainly endogenous steroids, that is the basis of the HPA axis. We also have melatonin. We also have sex and reproductive hormones, which have a diurnal fluctuation. If you look at it, all hormones have a diurnal fluctuation. When we get up in the morning, just before we get up, there is a corticosteroid peak inside the body. Actually, that readies us for all the physical activity that will start once we are awake. Right? It's not the breakfast, but it's the endogenous cortisol peak that kind of energizes us. Women have monthly fluctuations in estrogen, progesterone, and other hormones by which the menstrual cycle is laid down. Those are different types of periodicities. Over a longer period of time, there are peaks where in early childhood, there is a tremendous amount of development happening, a period of relative quiescence, and again the adolescent peak comes up, and so on and so forth. And of course, given all these things, there are so many individual variations, including sexual dimorphism, which is a determinant for neural development. So to put it in very brief, it is never a straight line from gene expression to hormone. It's all in loops and circles. So it is a non-linear association. I might have a certain kind of genotype, which will, let's say, determine how my brain is going to function. Brain activity will decide what are the hormones that are going to come into play, how and when. These hormones can change my genetic expression. This is a small loop. But what experiences I have had since childhood, right from in utero till now, will also have an effect on brain activity. Brain, as I mentioned here, is plastic in nature. the same experiences repeated over time is going to produce plasticity, change in this, will change in this, will change in this. So this is how it goes on. What are the different types of growth patterns? So as I said, growth is not linear. So it is differential, means different parts of the brain, different regions of the brain, different hemispheres of the brain, there are differences in growth. So it is intra-regional within the region itself, inter-regional between, let's say, right and left, and hemispherical. Protracted growth. One, we need to understand that children are not small adults, right? Developmentally, they are much more different at different phases of development compared to adults. Growth in human beings is protracted, means the growth and development proceeds well into adulthood. Well into adulthood would mean beyond ages of 25 and 30. So if that growth is protracted, we should not, as I said, make the error of labeling children as youngsters. Very simple as adults. A simple example, I will not tell any of my child patients, see, this is so very easy to understand. Your mother has understood, your father has understood this. Why don't you understand it? Not possible. If I'm going to tell the child, this is what it is, you should follow this, okay, it's not going to be done by the child. I cannot expect that to happen, simple because he or she is not in that phase of growth, which is my phase of growth that I am in right now. So I need to change my approach to the child accordingly. There are phases in neural development called as pruning. So the idea of pruning is use it or lose it. So the synapses that are going to be used over and over again become strong, develop more connections, and the ones which are not useful are going to be pruned or cut out or lost. Adolescence is a time when there is maximum pruning. But before adolescence, there is a time when there are lots of synapses. So there are going to be lots and lots of there's going to be lot and lot of brain activity which is not adult level activity. The brain organization is in terms of nodes and networks. We will not get into any details, but what a network means is that there are different regions of the brain that connect with each other to form an activity. For example, let's say emotional processing. What does emotional processing mean? Emotional processing means that there is a stimulus. This stimulus causes the production of certain emotions, let's say fear. Okay. So let's say I am experiencing threat. So I am fearful. The fear is generated by the amygdala. And this amygdala input of fear that is produced is carried on to the prefrontal cortex. And the prefrontal cortex has to exactly analyze this input, give it a label of fear, and also decide what is the response going to be, what is the motor response going to be, what is the cognitive response going to be, right? This is called as emotional processing in very brief. So this requires the whole network. What is the network? Sensory input that comes through the thalamus is relayed to the amygdala. Fear is generated. Impulses, this information is carried to the prefrontal cortex, the orbital prefrontal cortex, then the lateral prefrontal cortex, then the motor cortex, then the basal ganglia, because that is going to determine the motor input, goes to the cerebellum, which refines this kind of input, sends information back to the prefrontal cortex to decide whether it is all okay. This is the network. Now, all activity in the brain is network based. We have always learnt about different areas of the brain, but areas do not work in isolation, they work in terms of networks. Another component of pattern is lateralization. So our brain is unique in the sense it does lots and lots of activity given the volume that it occupies in the human body, and it does it very economically. And to economize, there have to be areas which are specialized. If every area does all the activities, then there is going to be an information overload and more likely of systems failure rather than efficient output. So lateralization, for example, logical thinking, left DLPFC, right? That is unique. Motor speech area, Broca's areas, left. Okay. So to give a very small perspective, this is the time period at which the development happens. This is overall brain. So if you look at frontal lobes in girls by 11, there is a good amount of development. In boys around 12 years, it's about a year's difference. And when we look at children by 12, there would be a good amount of prefrontal lobe development. I am saying good amount because it is not complete. If you look at the parietal lobes, it is almost similar. So maybe from 10 to 12 years, that's in girls and boys. As I said, there is going to be a difference in the sense there is a sexual difference here. Girls maturing fast, here. Okay. When it comes to language, emotion, and memory, it takes time. They are well into their teenage years, around 16 and a half. Again, there is a difference where boys mature a little bit faster. So this is how development happens overall in the brain. It is not uniform because all areas of the brain, all lobes as it is, they develop differently. There's a sexual differentiation, right? This is, this is a graph which shows if you look at the different areas of the brain. That was more about lobes in general. This is more about specific parts: thalamus, cerebral white matter, cerebellum, gray matter, so on and so forth. And if you see these graphs, this is the age in years: 10, 15, 20, 25, 30. This is the age in years. Okay. And if you see, everything grows differently, everything develops differently. These are not the same lines. If everything was same, it will be a line like this for all of them. This is white matter. If you look at adolescence, so let's say till about 12 years, the long white matter fibers, they develop faster than smaller ones. The smaller ones are still immature during adolescence. Now, what it means is that even though grossly a function may be acquired, fine tuning takes more time, well into adolescence, sometimes into adult age. Excuse me. So, as I was saying, there is something called as a network. Okay, network is different components, different parts of the brain. So we have medial prefrontal cortex, we have superior frontal gyrus, we have parahippocampal gyrus, parietal regions, cerebellum, retrosplenium. This is a schematic diagram. Now, what is important is this. If you see the red dots, they are the same. In children and adults, they are the same. But if you look at these lines means the connectivity. And the thicker the line, the more connected it is. So if you see, even though a child has got all the brain areas, how these areas connect with each other is much different in a child compared to an adult. This is a more efficient working network because there are connections, interconnections, strong connections. This is the concept of a network. Now, to give you a very simple example, if given a task and a child has to think, the child will think, but given this network. If I gave the same task to an adult and the adult is supposed to give me an answer, this is the network that is going to come into play, which is much more efficient because there is so much connectivity, so much easy flow of information, so much ease of decision making that the answer comes out fast, the answer comes out efficiently, the answer comes out complete. Same task here is going to give me a totally different kind of a feedback. Now, when we are talking to children, The same question that I ask a child or an adult, if I ask an adult, what is wrong with you? The adult will be able to tell me that he is not sleeping well, he is not feeling well, he is not eating well, he feels that he is not able to focus. And this kind of an answer will come without prodding. And the child may say, I don't know. Brain is the same, the areas are the same, the connectivity is different. And this is going to determine not only what the symptom is going to be like, but even the experience of a symptom and what kind of an impairment it causes in children is going to be much different. Maybe more number of questions will have to be asked. Maybe I'll need to make myself more and more clear to the child in very simple words as to what I am expecting as an answer from the child. Now, this is a very simple diagram. Just focus on these colors here. This is the medial part of the brain, orange. This is the lateral part of the brain, orange. And this is the brain we are looking from below. So this is the basal prefrontal cortex here, and this is the lateral prefrontal cortex here. Now, why these two diagrams is this is the brain function that is going to be encountered when I'm looking at child or adolescents. Why? Because this is the orbital prefrontal cortex. This is the area which receives all the emotional stimuli coming from lower centers, and this is actually going to relay this information to the prefrontal cortex. So a fully developed adult brain is going to take decisions based on this. Why? Because this connectivity is well established, this connectivity is very efficient, this connectivity is going to take good decisions. So when I'm talking to a child, since this is not very well developed, in the sense the connectivity is not very well developed, the child is not going to comprehend what is wrong with the child. I didn't like what my mom said, so I'm crying or I'm very upset. An adult will be able to say, somebody told me something, I was upset, but then I thought, well, it's okay, it happens. So the reactions, the responses are also going to be different when it comes to a child to an adult. So now coming to the clinical part, keeping that in background, a child is generally 0 to 12 years and an adolescent is generally 13 to 18 years. So teenage is adolescence, child is before that. An infant is from birth to the first year of life, and toddler is from the first year to the third year of life. This is a small subset of child, right? So this is how we are going to understand a child or an assessment of a child when it as is today's topic. Now, when we give a diagnosis, actually it is a small part of something called as a diagnostic formulation. And what is this formulation? A formulation is a meaningful synopsis. It is not a summary of the case, it is a synopsis in very brief, precise, concise manner. A formulation is a mode of communication between clinicians and referring authorities. So if a child has come to me, has been referred to, let's say, by me, by one of you, and I have to communicate to you what I have understood in terms of this, then I have to make a formulation. The formulation is an easy way of understanding what is happening with the child, what needs to be done, what is going to be the outcome, what are the resources that are going to be needed, and so on and so forth. If a school has referred to me a child and I need to get back to them, of course with parents' consent or whatever, then a formulation is necessary. It is not only important to write that this child has got, let's say, specific learning disability, because the authorities may not know what is specific learning disability. And it is no point when they refer to Google and say that SAD is this. It needs to be coming from me as a psychiatrist and not from Google, even if both are correct. It is a mode of education, because once this formulation is clear, then what are the issues that need to be addressed? How do we go about addressing those issues? What do they mean? Is going to be a mode of education. And a formulation is basically a test of my communication skills, the level of confidentiality that goes into making this formulation, because it is going to be shared with others, and the ethics, all those ethical principles that Dr. Joel mentioned to in the previous term. So when a child is brought to us, by child I mean 0 to 12 years, what are the things that a child brings to the table or is going to bring to the table is much different from what the parent is going to tell me about this child. So what are the influences in the child's life at that point in time are going to modify the child's narrative, what the child is experiencing, and it may not be the same as what the parent is perceiving. Okay, as I said, a child is not a mini adult. Never make that mistake. A child is a totally different entity at that point in time, given that level of neural development, given these influences, and I have to tap into all these things to make a formulation. So coming to infants and toddlers, so infants is the first year of life and toddlers is the second and third year of life. Now the important thing here is that these individuals are never going to be able to give me any relevant verbal information. Why? Because there is a level of cognitive development, there is a level of speech development, there is a level of emotional development, social development, which is needed to have a good communication. So the communication with infants and toddlers is going to be more different than what is also going to be done for children. So most of the information is going to be given by the caregiver. And we better be very precise in obtaining all the information from caregivers. Now, by caregivers, I don't mean only parents. There would be grandparents in the house. There might be some attendant in the house. If the child is in foster care, all those people who are managing the foster care. If the child is in an orphanage, then the attendants in the orphanage are all caregivers. So it is not only parents. The important things I need to get from that history is the family history in details. Family history is a lot of things about what is happening in the family stressors, family issues, but most important, it is the family history of psychiatric disturbances, family history of genetics, including medical illnesses. That is important, right? History of pregnancy, delivery, perinatal period. It is important here, very important here, because this phase is very close to this phase. So sometimes things get carried over. Not that they do not get carried over later on, but when they get carried over later on, the presentations are different. So if there is a history of hypoxia, for example, okay, let's say if it was a very troublesome pregnancy, pregnancy related hypertension, pregnancy related diabetes, pregnancy related psychiatric disturbances, some of the immediate effects can be seen in infancy also. If the delivery was prolonged, there was fetal hypoxia, assisted labor, if there was a perinatal issue with the mother in terms of, let's say, perinatal mood disorders, then all this is going to have an impact on the infant and toddlers and childhood. But as I said, this period comes closer, so definitely we should not miss. Developmental history, as I said, medical history, from the caregiver, what is the nature of child care, what are the family arrangements, child psychological role in the family, caregivers perceptions and expectations of the child. Yes, by 2 years my child should be able to read, write, start coding, start preparing for IIT, JEE. All this starts very early on in life. So we need to be very clear about what is happening in terms of perceptions and expectations, which might be troublesome at times. Stability of home or family environment, family social support, as I said, a very detailed family history. Now, when it comes to infants and toddlers, as I said, they are not going to give me a full mental state. So if I'm going to ask my first question to the child, how are you feeling? The child is not going to understand at all and will continue doing whatever he or she is doing. So what is going to be important is a detailed observation. I can talk to the child depending on how much the child is able to speak, because we know that language development takes a lot of time. By 2 years, a child can speak a few words, not a meaningful sentence. By 3, they should be able to speak something, small sentences, maybe grammatically not very correct, but the language may not be clear. So asking complicated questions, how do you feel? How do you think? Not going to give me answers like that. So observation of physical health, appearance, and growth parameters, most important. Look at the child, see how the child looks. There would be some obvious markers of growth impairment. Okay, sensory development, focus on vision, hearing, tactile. So usually parents, at least in Mumbai, they'll come with a file from the pediatrician. So all these things you do not have to really get into details because everything is noted. Gross motor development, fine motor development, communication development. Now what we need to understand is all these developments, they are on their own trajectories. So whenever there is a delay or arrest in any of these issues, development in others can get affected or may not get affected. For example, if there is a fine motor development issue, okay, a child may not be able to hold a pen, pencil properly, okay, might not be able to balance properly, but might not have a problem in communication development or let's say walking or running, but he might be a bit clumsy, right? So these are not going to proceed in the same fashion. As I said, this development is always differential. What we looked at in the first part of the was the brain development pattern in general. So as development progresses, these parameters also progress, but in different speeds. So we also look at expressive communication, speech clarity, and fluency. Okay, cognitive problem solving, it's not very complicated things, but you, let's say, give them shapes and see if they're able to fit in properly. That's about it. Whether they're able to do a standing line, sleeping line, developing a sense of self, social relatedness and interest in environment, capacity for effect, that is mood regulation and coping skills, emerging mastery and motivation, and capacity for symbolic representation and play. Now, we have got many theories for development. So for cognitive development, we sometimes refer to Piaget's theory. Okay, when there is this developing sense of self, we look at, let's say, Ericksonian stages of development. But what is important is that these are observations. The underlying basis of any of these theories is the previous section, how well the brain has developed. If the brain is developing properly, then all these capacities develop properly. If there are issues with development, this will get affected. So these theories give us an external observational clue about what is happening with the child, right? How they deal with numbers. So a child at 2.5, 3 years, if the child is attending, let's say, preschool, he will be able to tell me A, B, C, D, maybe the whole alphabet. But even if the child is not able to give me an alphabet but knows some in order, it is good because it is not formal education. But more important is how the child is related to the environment. Whether the child is able to interact with other children, whether the child is able to ask for something when in distress, whether the child is sharing, right? All these things are important because this is social relatedness. It's a social it's a social developmental trajectory, right? If something happens here, there is an issue with socialization, the child might be presenting with symptoms of autism spectrum disorder. But we need to look at it. Parents will come and say the child doesn't look at me. My question is, why should the child look at you? If the child is interested in doing something else at that time, when you want their child's attention, the child may not look at you. But then the mother will say, no, it happens all the time. Okay, then there seems to be a problem in social relatedness. But I should be able to understand what are these normal patterns of social development when it comes to the first few years. Whether the social smile was on time, whether the child looks at somebody, whether the infant or the toddler looks at somebody when that somebody has called him or her, whether the child shares things, something interesting brings to the mother and shows, right? When taken to a garden, whether the child interacts with other children, plays with them or plays his own game when in a group, right? Another important thing is affect regulation. Is the child cranky? Anything happens, the child starts crying. Is the child able to comfort himself or herself? Okay, right? What are those skills? How is the child dealing with the environment? Well, is the child able to use a mobile phone? Given a mobile phone, can the child get onto some apps? This is a skill. Okay, yeah, it might be a controversial area about screen time. We are not getting into that, but anything in the child's environment will be picked up by the child, explored, and mastered. That's why children, we might have been using a mobile phone for the last 10 or 12 years, 20 years at the most. But even with this 20 years of fiddling around with mobile phones, the same mobile phone in the hands of a 2 or 3 year old child will be handled much better compared to 20 years of use. Why? Because for us adults, the instrument or the equipment entered very late in our lives. But for a child, it is entering very early on in life. So the ability to explore, curiosity, mastery, and motivation is much higher in infants and toddlers than at any particular age. I know of many parents who will come and say, Doctor, he's whatever the issue is, give him or her that mobile phone, can go onto any app, can switch on YouTube, see poems, videos, play some simple games. And for an older child, when my phone gets stuck, the child knows how to go about opening that. That is called as mastery of environment. Capacity for symbolic representation and play, another very important step in cognitive development. And we also look at both of them together, that is a caregiver in the infant. How does the infant interact with the caregiver? Parents will say we are doing the best, but when you make them sit together, then you know that, well, the best is really subjective. What is a caregiver's attunement and responsiveness to child's affective state? Each time the child cries, what are you doing? Give the phone in the child's hand. Well, then that becomes the child's emotional support. Then a parent cannot complain that no, child is spending too much time on the mobile phone. Elicitation and receipt of positive interactions. What kind of an interaction is happening? What kind of feedback or a reciprocal good job being given to the child? Security of attachment between the caregiver and infant, and the caregiver's effective response to child's efforts during assessment. So it is very common when I ask a child, let's say a child has got ADHD, symptoms of inattention, may not be full-blown ADHD at this age. And I ask the child, what is your name? And the child looks here and there, is busy playing, looks at me, gives me a smile. Okay, back to play. And then the parents will say, doctor has asked you a question, answer. Okay, it's fine. I know what is happening. The child is being inattentive. Okay, so parents think that the interview with the child is an exam which needs to be scored and aced. Sub answer barobar. I'm not interested in that. I'm interested in what the child is answering and how the child is answering. Okay. So this is basically an observation of infants and toddlers. This is basically taken from IPS clinical practice guidelines for assessment in children and adolescents. So these are some of the things that I talked about: fine motor, gross motor, cognitive, but at different age, what I can expect. Okay, if this is not being fulfilled, then I'd worry whether there is a developmental delay or any specific pervasive developmental delay which is causing a problem. So now, as I said, at 2 years there will be 2 or 3 word sentences. Okay, so I cannot expect this child, toddler of 2 years, to have a very lengthy conversation about what is happening, about life in general, about politics and things like that, right? So I need to ask my questions accordingly. So this is the same thing, but at different points in time. Okay, sometimes to be more kind of have an objective assessment. See, these scales are nothing new. They are just questions based on all these things. But you can tick it, give it a rating, yes, no kind of thing. Now, why important is because if something is happening and if I am able to have a baseline assessment using this, well, then it can be important to have a before after kind of thing. So now let's say the child is under treatment with whatever for 6 months or a year. And if I do it again, I would know what has progressed, what has not progressed, what has regressed. Coming to children, that is now, let's say more than 3 to up to 12 years of age. What are the important things? First, no child is going to come to us saying that I have a problem. Okay, no child. Rarely, if at all. So in my so many years of practice, there is no child who has come to me saying that there's something wrong with me, I need treatment. No, it doesn't happen with adults also, so it's not going to happen with child. And children function differently in different settings. So especially when children are older, sometimes I tell them that why don't you get your friend along to meet me, your best friend, if the child is able to come. Or I ask parents that tell your child's class teacher to have a word with me. And you get a lot of surprising information as the setting changes. Parents see the child for some part of the day, rest of the time they're busy with their stuff. A child is a child at home. A child is a student at school. A child is a friend with so many other children when he or she goes out to play or have fun. So in all these settings, the child may behave differently, given the same problem. So it is important for me to get all these things because I am interested in knowing this. Emerging mastery, motivation, how the child is handling himself or herself, how related the child is. Okay, important. This the parents can give me an idea, but to be more accurate, I will need this information from different settings. So, a child interview can take place at home. Home visits I don't do now in times of corona, or in a school setting, or in your clinic, or in special setups. Presenting problems must be examined in a developmental context. I'm saying this again, a child is not a small adult. Alliance with multiple parties will be needed. You need to be one needs to be very, I would not say excellent at social networking, but needs to be able to manage multiple people at the same time, whether it is parents, teachers, caregivers. Sometimes children are brought to us are referred to us by various authorities for assessment. So liaisoning with them. Who do I start talking to first is a big issue, because many times it happens. Parents would like to say, I'll talk to you first and then we'll talk to my child. And then they'll give me all the details. And then the child will come and say, I'm sure, doctor, you have heard my parents. Okay. And they must have told all things about me. Now, the tone in that is, well, you're going to side with my parents. Right? So who do I start with? Okay. So as far as possible, I talk to the child first, unless the child is very uncooperative. The second best issue is call all of them into my chamber first, ask what is happening, and I'll tell them that in just 5 minutes, tell me what is the main issue. Right? So when this is a pressure, time pressure, believe me, it's a pressure for all of us. It's very difficult for all of us to stick to the point in a very brief period of time. And unless and until you get it, you will be moving round and round in circles. So parents will say, being naughty, this is fine. And then I say, okay, now wait outside. So now what has happened? The child has heard. Okay. The child has also assessed that I am trying to get to the point. The child is also happy that the parents are out. And then I ask the child, well, this is what your parents have to say. You tell me whether it is right or not. Right? And this is the time when even the child decides that, okay, something is expected out of me. And I'm trying to be honest with him. Well, this is right or not. I'm not saying, see what your mom said. Are you being naughty? No. So I said, you tell me what's right, what's wrong, whether they are accurate or not. And that is when the child is more or less okay with me being present in that cabin. I've heard what parents say, and now I'm interested in hearing him or her. And so the child says, yeah, sometimes I'm naughty. So I get the same thing from the child, but from the child's mouth. No pointing fingers, no judging. Fine. So I have to avoid being judgmental at all times. The child might be really, really problematic. Those who have issues with conduct, right? A lot of behaviors that I may not like, but that's fine. I don't like it. So I don't doesn't mean that the child is not going to do it. The child has to be treated or advised or whatever. So yes, fine. It's okay. Let's see what we can do for the child. And sometimes engaging children can be very difficult. So the idea is that I'm going to assess a child completely in one sitting or two sittings is not true. Sometimes to exactly understand what is happening will require more than 2-3 sessions or interviews. So I'm in no hurry, right? Because unless and until I am certain as to what is the specific problem, as I said, we'll be going on in circles, and we have to be prepared to go on circles. With children, as I said, we will not use jargon. We'll just use the language that they are comfortable with, right? So there's no point in asking the child, "Are you depressed?" Right? Or "Are you stressed?" So easier things would be, "Are you happy? Are you okay? Do you feel sad? How do you deal with this problems?" Current illness is most important. As I said, focus. Parents will come and say, "Child doesn't behave properly." The question is, since when? Since childhood. Doesn't lead us anywhere. So why have you come now? That is where the current illness will start. No, since 6 months we are feeling that he has become more irritable, and start with that. Past history, what all has happened in the past. Safety assessment is important because suicidal thoughts and behaviors are also seen in children. It is not an adult phenomenon or an adolescent phenomenon. Even in children it happens. Okay. Comorbid physical and psychiatric disorders. Well, the rule that surpasses all the rules is, I mentioned it before, that no psychiatric patient, including children, come with only one psychiatric illness. And in children more so, since they are, as I said, there are a lot of parameters for development that need to be looked into. A child can present with ADHD, for example, but will have a lot of pointers towards a specific learning disorder or conduct disorder or some autistic symptoms. So it's not going to be one. We have to look at all these things. Substance use also is there. Teenage as a concept, which has nothing to do with adolescence, right? Teenage like behaviors. Okay. That concept I'm saying, I'm not talking of the age, is no longer limited to teenagers. You can see a lot of adolescent like behaviors even in younger children. So substance abuse or experimentation comes early, right? So this is again a chart which shows developmental disorders, mood symptoms, disruptive behaviors, and learning disorders. How do they manifest in young children and older children? Okay, so there is no break here, but as children grow older, the same category of disorders are presented differently. Okay, so if you have a child who, let's say, who has got disruptive behavior disorders like ADHD, okay, right, externalizing behavior disorders, disruptive behavior disorders, ADHD conduct, common things: back answering, not obeying, teasing children, starts fights, frequent complaints from school. But in an adolescent, there will be more well-defined conduct-like symptoms: argumentativeness, lying, stealing. So the same kind of presentation will have same kind of a disorder will have a different kind of a presentation as the age group changes. So when we look at development, as I said, developmental perspective is very important. We look at all these areas of development: basic functions, motor, cognitive, interpersonal, emotional, temperamental, moral, and trauma. Because this kind of situations have an effect on all these things. Okay, So some useful pointers as to how do we start. Psychomotor, very easy. When did the child start sitting, walking without support, jumping, running, so on and so forth. Cognitive, okay. How did the child, does the child point to things? How does the child understand letters, alphabets, numbers? Is the child able to recite poetry and so on and so forth? So these are the areas which we need to ask. Okay, including moral development, sense of right or wrong. Now, more important, also important is like when we do an MSc, when we take a history for an adult patient, there is also the last point in history which says pre-morbid personality. And sometimes that pre-morbid personality, that thing remains only for that thing. We do not consider, we generally don't give much weightage to personality when we are treating even a primary psychiatric disorder. For us, it is there. Patient has got cluster B personality traits. The question is, if a person has got anxiety or depression and has got cluster B personality traits, how is it going to modify the disorder? That is important. One. Second is, are there any components in that personality which are modifiable by treatment? Because all that has got an impact on what you are actually treating. Equivalent to a personality, pre-morbid personality in a child, we have got something called as temperament. Now, these are traits. These are not well-defined behaviors. These are traits, activity levels, how energetic, rhythmic patterns, distractibility, approach withdrawal, adaptability, attention span, intensity of reaction, responsiveness, mood. Now, these are components which will vary differently in different children and can be the underlying basis for some other disorder that is going on. So if the child is excessively moody, cranky, then the question comes is, how is the child modifying the mood? If this is there and the child has got, let's say, a problem like ADHD, how is the child going to manage that? How are you going to manage that? Becomes important. So an assessment of temperament is very close to what the child has right from day one of life. These are given things. And these things kind of become more clear, more crystallized into a pre-morbid personality as the child becomes an adult. Another thing that is important is the culture, of course, cultural identity of the individual. Now, culture basically is a set of environmental stimuli or inputs that is given to a child. Okay, I can be born in a certain culture, but basically I am born with a certain genetics. This is going to give me additional input on that, and then I can develop my own cultural identity as an individual. All our illnesses have got cultural explanations, right? All we deal with our environment and stresses depending on the culture. I might be from a different culture and my patient may be from a different culture. So this is one thing which is going to create a problem. So the golden rule is never be judgmental. There is a culture of childhood which keeps on changing. So there is nothing like a golden childhood period. We see lots of WhatsApp messages every day saying, oh, childhood was a golden period. But for a child of today, that would have been a period which is useless, has no meaning. Okay? So our childhood, my childhood, or the culture of childhood is much different from somebody who's 10 years old now. Interactions with peers and participation in childhood rituals. This also keeps on changing. Right? For some children, having the first cigarette was a childhood ritual. They may not have become smokers or have had nicotine issue after that, but it was a childhood ritual. So there are many such rituals. Televisions, games, sports, movies, books, and social media, all this keeps on changing. But it's a part of the culture. It cannot be denied. It cannot be minimized. Okay, it has to be given attention to. For children, the family history should include genetics, yes, stress, conflict, effects on development. Okay, whether the child has been adopted, medical history, school regarding education, bullying, abuse, other activities. For a more objective assessment, a mental state examination, mini mental state examination are almost same, except that the questions will be different. You need to give more time. They're going to be incomplete, so they will be done repeatedly. Projective methods can be used. Give them a pencil, paper, or crayons. Let them do whatever they want. Psychometric assessment, academic assessment if needed, lab testing, nothing specific, will depend on the disorder. EEG, imaging, genetic testing. If I'm confident about genetics, I might ask something on my own. But whenever there is a doubt, if there is going to be a syndrome or something, a referral may be needed. There is nothing wrong in a referral. By that referral I mean a pediatrician's referral or a neurologist referral or whatever. Now, once I've got these informations, all these things, as I said, the idea is to make a formulation, which is to make a complete, concise, precise summary, which is going to be the model for my treatment, which is going to be a model for explaining or making the patient's relatives understand, for communication and so on. So the most common model for formulation is a 4Ps model. So predisposing factors, precipitating factors, perpetuating factors, and protective factors. Right? If we have a kind of a formulation using all these 4Ps, it is like a Patri, Janam Patri, gives all the details. So what are the vulnerability factors? Which would be family history, genetics, medical psychiatric histories, chronic social issues. Right? These are there. Background. Precipitating factors. Current stressful events, inciting events, concurrent illness. So when a patient comes to me, when the parents say the child is always behaving badly, there is something going on here. It's a predisposing factor. Why now? Since 6 months, there is a problem. Why? Because the child fell ill, had got corona. After that, I feel that the child is more irritable. That's a precipitating factor. Perpetuating factors are the factors which will continue the illness. Illness will go on and on. Why? What is happening? If it is very severe, okay, we are not clear as to why this is happening. So sometimes there are no stressors. Most of the time there are no stressors. Whether they are adherent to treatment or not. No. I have had so many patients, children, who are clear-cut ADHD. When I say that we need to start them on methylphenidate or atomoxetine, no, we'll take a family meeting, we'll decide. We are not for medicines. People have said medicines are not okay. So then I give them the necessary gyan about what is treatment and what happens. Then they say, doctor, can we get back to you? I said, fine. This is what is my observation. This is my assessment. This is my recommendation to you. You can take your time. Get back to me. So they take time with TIME, all capitals, and this goes on for 6 months to 1 year. Then they come, doctor, we had met you 1 year back. Really, I don't remember, because I don't remember patients which I saw last week also. I see so many of them, so difficult. So tell me. So then they'll produce that old paper, or then otherwise I'll have to start all over again. And then they say that, doctor, you had mentioned treatment last time, but our family decided that we'll wait out, we'll do only therapies, and we'll do only omega-3 fatty acids because that was there and all those things. So like, what happened? No, the child's academic record has deteriorated. We get a lot of complaints. Okay, right. So all these things, we go all over again and then we come back. The diagnosis is still ADHD, but now the child is just 1 year older and I can see some conduct symptoms coming up. So, well, I would suggest treatment. Doctor, medicine, can we continue with therapies only? We have heard about sensory integration. The treatment of choice for ADHD is medical. You have given about 6 months with some therapy, about a year for some therapy, nothing much has happened. My recommendation still remains the same. And I think that as the time goes, and if you're not able to intervene as early as possible, there will be still some more things that will develop. Now we are seeing conduct issues coming up, we might see something else. Okay, doctor, we'll see. You can give me a prescription. So prescription given for 15 days, first time for methylphenidate, then they'll come after again 3 months. What happened? Did you start treatment? No, doctor, we read about methylphenidate and there are so many things that we wanted to clear. So we asked our pediatrician. Pediatrician says you wait. Okay. So this is what happens. Perpetuating factors. Time is not a healer for any illness. Okay. If you do not do anything about it. What are the patient's protective factors? What are the patient's strengths? Well, the patient is able to manage himself or herself emotionally better, even though a child, good. That is the resilience, good supportive family, right? Another way of formulation is the 4 perspectives. What are these perspectives? Disease, dimensions, behaviors, and the life story. It is similar to this, but not the same. And what does this mean? What is the disease? What is the problem? As I said, sometimes it's very difficult to pinpoint a problem depending on the history. Takes time. So my biomedical perspective is that it is ADHD. So what is the treatment? If it's a illness I have to treat, I can't let it go. So I have to suggest treatment. So that is a disease perspective. That is a doctor's perspective. What are the dimensions of this illness? What are the vulnerabilities that this person has from beginning because of the illness can cause a problem with the progress or the prognosis of the illness? What are the behaviors that are problematic? Okay, even in that ADHD, so vulnerabilities is basically the patient's perspective. This is my perspective, the patient's perspective. This is the everybody else but the patient's perspective, behaviors. Naughty child, school perspective, not doing well in school, school perspective. The child is not able to do anything at home. I have to tell the child again and again the same thing. I beat the child, parents' perspective. When the child goes to play, ends up fighting with other children, other children's perspective, so on and so forth. And the life story. Life story is basically the narrative. What is happening with this illness, with this vulnerability, with these behaviors to the child? What does the child actually want? Child is not bothered about ADHD. Child will say, I should be able to do well in school. Or more commonly, I should be punished less. I should be allowed to do, let's say I like playing cricket, so I should be allowed to play more. That is the life story. I have an illness and the treatment to look to. These are the givens that a patient has. This is what everybody else thinks about it. And this is actually what the child wants. These are the 4 perspectives. This is a little bit more theoretical. If I need to share certain things with others, I would follow the 4 P's model. Right? So what a patient has, cure, problems can be, as I said, medicines can be toxic. We need to look at compliance in spite of these things. What a patient is, what a patient does, what a patient wants. So thank you. This is all I had to discuss with you people about what goes in assessing a child. If there is time, we can take some questions. Thank you so much.
Thank you so much, Dr. Dave, sir. Are there any questions from the audience?
Dr. Malay, at the outset, I would like to thank you for such a comprehensive talk. Malay, I was very interested to know more about you. You raised a very interesting concept of epigenesis. You know,
Yes,
being
yes.
in the perinatal task force, I was quite fascinated to get more knowledge from you. That do you think through the process of epigenesis, we could prevent the manifestation of psychiatric disorders in infants and children? For example, say a lady is depressed, okay, and genetically she has, say, passed on that vulnerability to the infant or the child, and this weighs a lot on the mind of the families, you know, that should she even have a child because she has suffered from depression during the pregnancy. So do you think a nurturing environment, a good healthy diet, all these factors through the process of epigenesis could prevent this gene expression? You know, if that would be one way of, I feel sometimes, to encourage my mothers that, you know, there are ways that we can probably prevent and you can have a healthy child. I know this is an area of research, but you have read quite a lot. And if you could enlighten us a bit more on the process of epigenesis, because that's something that's fascinating me a lot in the role of prevention of disorders manifesting in infants and children.
One. Yeah, thank you, ma'am, for the question. First thing is epigenesis is not just kind of a translation of experiences into something. It is a very complex process, and as you said, it is an area of research. Now, coming to your query, first and foremost, what our understanding of the genetics of psychiatric disorders says is that there is no preventing a psychiatric illness. It can come. It is not only epigenesis. Okay, it is not epigenesis. It is basically genetics. So for a mood disorder, let's say like depression, there will be so many genes involved. Right? It is not one gene. Second, there are so many genes involved, we hardly know most of them. We know some. Right? Second, another thing. Apart from the vulnerability, there are so many other factors in utero which can alter the epigenetic profile of an individual, of the fetus, for example. And now we know that even the maternal microbiota, gut microbiota, is also going to have an effect on the child, because that also passes through the amniotic fluid. Now, that would mean that we need to have an in-depth understanding of so many factors, right? The question then comes is how we are going to modify these factors. Good nurturing care is one. Is it going to alter the genetics? It is not going to alter the genetics of the fetus. Okay. Is it going to alter other epigenetic factors? Maybe not, mostly not. So the good thing is that even if a mother has got depression, the chance of inheriting that depression as an illness is very low. Okay. So roughly, if we go by the heritability studies, if a mother has got depression, the child has got not more than 5 to 8% of developing depression later on in life. Means more than 90% of the times the child is not going to have any problem. So unless and until we are really sure of what factors we are looking at, if we understand them very well, then only we can actually try and figure out how to modify them. Epigenesis is not switch on, switch off. There are a lot of things that get into play. The whole chromosome gets affected because of the genetic marks, as we say, epigenetic marks. So it's not going to be switch on, switched off. In fact, epigenetic changes that happen can be lifelong. Factors that can affect, as I said, are many, of which one of them is good nurturing care. So bottom line is we can do whatever. Whether we'll be able to prevent it, we are uncertain. Whether we are going to modify an illness that is going to be there, we are still uncertain, because the genetics of psychiatric disorders is cross-cutting. Means we are going to have some genes which are common, let's say in bipolar and schizophrenia, some different. We are going to have some which are common in, let's say, depression and ADHD, some different. So again, we are not very clear, because it's not one gene, one disorder. It is not one epigenetic insult, one disorder. So too many factors at play. It's a good area of research. We can, I mean, of course, it is always good to implement all kinds of good things that we know about, with the hope that it will prevent. So no 100% certainties, no magic bullets.
Yeah, thank you, Dave, for enlightening us so much. No, why this question came to my mind, in Indian culture, the first 1,000 days, they say, is very crucial in a child's development. If you see, even in our policy, that first 3 months, at least the mother should be there with the child, And this point that you raised about gut, the gut-mind connection. A lot of area being researched on how the microflora can affect the mind, and there's a connection between the mind and the gut. Of course, like we said, there's so many factors coming into play. But in policy changes, this presence of the mother or any nurturing person in the family being available for the child. Even in animal studies, you've seen simple studies like on the monkeys. If you separate the mother from the child is not growing well. So this was just a thought in my mind that if the genes are inherited, the manifestation of that expression, would these factors come into play through the process of epigenesis in one way to prevent? Because prevention is not there in psychiatry as yet. We know the genetic vulnerability, but we still don't know, like you rightly pointed out, if the genes alone are the sole factors in the manifestation of a disorder. Thank you, Malay, for enlightening us so much. And please do give us some more references if you could get through this process, because I see you, going your interest in this area. It could help us learn more and, stimulate our PGs to work in these directions. Thank you so much.
Thank you.
Thank you, sir. So our next session, the speaker will be online, Dr. Rachna Bhargav. She is currently working as an additional professor in clinical psychology, AIIMS, New Delhi. And she was earlier worked in Department of Psychiatry in Chandigarh as a faculty member for a decade. And she is also involved in child guidance clinic, behavior addiction clinic, and adolescent addiction in AIIMS. She has been a WHO Global Mental Health Scholar and recipient of several awards, including Marfatia J.C. Boral Award, B.K. Verma Award, and reviewer in several national and international journals and more than 50 publications. And her area of interest are child and adolescent mental health, including drug use, behavior addiction, psychological intervention, and disability. So we all welcome Dr. Rachna Bhargav, and she will be talking about familiarization with psychological tools in clinical practice. Welcome, ma'am.
Good afternoon, everyone. Am I audible? Am I audible to everyone? Am I audible to everyone? Can I share the screen, please? If you could make me the co-host.
Yes.
Before starting the lecture, I would like to know how much time I have, because I think we are running quite late. I don't know whether do I have an hour to make presentation?
Yes, ma'am. 1 hour time is there.
Okay. And okay. I would like to thank the organizers for giving me this opportunity to share my experiences. And I will, since it's a very broad topic, so I will be restricting to general tests and the basic how do we select the test and what are the use while doing the testing. So is the screen visible? So when one is talking about, I'll be talking about the need, why do we do testing, how we categorize them, and what are the various things that should be considered while making a referral for the psychological evaluation. Psychological testing is not synonymous to psychological assessment. In fact, psychological assessment is an umbrella term which includes interview, observations, and reviewing the records, and including psychological testing. Psychological testing can be cognitive testing as well as non-cognitive testing. I'll be going into more detail now. Before we talk about the various tests and the domains, we must understand that not all tests are psychological tests. I'm sure you all, the residents also would be familiar with this, that we often come across in the magazines, that know your personality or know your intelligence. They are not definitely psychological tests. So how can we, what differentiates them from the formal psychological evaluation? These tests have to be standardized. What do we mean by standardized? That there are strict guidelines that how do we administer, how much time can we give the subject to do it, what are the materials are required, and who should, and whether there are norms developed for it. So in a way, psychological tests, whosoever administer, we should arrive to the same conclusion. So there is an objectivity underlying a testing. The test should be reliable, that over the time, depending on the variable that we are exploring, the response should be same. The test should be, while constructing a test, one goes through a process of identifying the items and developing the item, that this is what, if I want to measure, let's say IQ, then the items are actually typing the IQ domains. And the norms, because if one is, since we are talking about the psychological test to be used in the clinical setting, we must know what is the average performance when we do it on a normal. We assume that a person who is having no psychopathology, how would he perform, so that we can differentiate whether there is a dysfunction or not. So for you can see this normal probability curve, and one can see that most of the, whenever we do a testing, we must know that how much are the scores that range in this 68%, the middle, the mean, where the peak is. So that's how we calculate the average performance of a normal individual. So in a clinical setting, there are usually the referrals are for diagnostic clarification, conflict, identifying the conflict underlying when the subject is not cooperative or is mute, or sometimes there is a need for tapping the organic signs, or which, if there is a lesion, or if which lobe is affected, to measure intellectual ability and to understand if there is a personality which is underlying the psychopathology. And of course, not to forget, for the management purpose, whether it is pharmacotherapy or psychotherapy, sometimes one needs to monitor, and for that also psychological tests need to be done. We can categorize the psychological test in two ways. One is whether it is a totally structured test, semi-structured or unstructured, or whether the test is verbal. That means that whether the instructions need to be verbal, or if the response has to be given verbal, whether it is performance-based, or whether a test is comprising of verbal and performance both. So when I'll start with the personality test, and here one can see that there can be totally unstructured tests which are based on projective tests, projective techniques, and there are self-report inventories. So the way they are presented and the way the subject responds to the questions, that decides whether they are structured or semi-structured or unstructured. So coming to the self-report scales first, I'll run through them because even if I have concised them, but I'm just naming very commonly used tests which are used in clinical setting more frequently. So the temperament, when we are talking about whether there is a temperament corrector inventory, very frequently used, although we don't have Indian norms for this available. And it's relatively a very, it has 240 items, but it gives us a range of personality traits and pathognomic signs that helps us to predict axis 1 disorders also. For children, excuse me, a test, a rating scale that taps various specific measures of personality and is useful for planning intervention with children. This is specifically for children. And then there is a scale which is very commonly known, but unfortunately, though sometimes we do use it in clinical setting, but actually it has been developed in the normal population and ideally it should not be used for clinical purposes. But sometimes one just wants to know for management purpose that what is the personality profile of an individual. So we use Cattell's 16 factor based on Cattell's concept of 16 factors. It gives us 16 personality factors and 5 global personality scales along with 3 validity scales. Over the time, Ising came up with a scale of personality. Originally, it was PEN, psychotism, extroversion, neuroticism, then EPI, and then EPQ, and now the latest being EPQR, comprising of 90 items. It includes a life scale also. That is the major advantage. Sometimes we are clear that the patient is not psychotic and we just want to know the general traits. If they are affecting the interpersonal relationships, then we go in for EPQ. EPQ has Indian norms, but why I'm emphasizing on Indian norms are not available, because in clinical setting, we often depends on the norms and we cannot compare with the Western norms most of the time. Coming back to 16PF, there are different forms depending on the level of literacy of the individual and the age of the person. We decide which form to administer. You can see that these are the 16 factors, and this is the kind of profile. And these are the higher order factors that can be derived based on the 16 factors that we derive. Anybody whosoever has any question can interrupt also, because I'm running through the slides because there is lots and lots of tests to be talked about. The recent personality scale that has come up is Big Five personality, which is based on Big Five personality theory by Megri and Costa. It comprises of 5 domains, each with 6 facets. It has 2 forms, self-report and observer rating. Both, unfortunately, initially were comprises of 240 items, which was pretty long. But now we have new FFI. It's a shorter version comprising of 60 items, and it is available in paper as well as computer versions. I'm here usually not emphasizing on the scoring and interpretation, because I felt that from a psychiatrist point of view, from the residency point of view, it's important that you understand what the test measures. And if you get to see, when you make a referral and when you get the report, you should be able to identify whether the test selection is right or wrong. Because many a times, if the test, even though, like for example, if I am doing an IQ test and the child happens to be ADHD and I have selected a speed test, then my interpretation would be wrong. So as a psychiatrist, you should also be able to pick which test should have been, at least you should be able to identify whether the test which have been administered is correctly used or it is giving me a wrong information. So based on what is being, what the case is being referred we have a battery of tests and we need to select which one to use. And it is not that randomly you can pick any and do it for a particular domain. So depending on the goal of the what we are trying to see, which is based on the initial clinical interview or the referral, and depending on the age of the child, because due to the development different patterns of the growing up child and adolescent, we have different tests for children and different tests for adolescent and different tests for adults, and in fact different tests for persons with old age. I'm talking about general adult scales, but I'll be mentioning wherever there are specific children's tests available. Now, talked about Erlanger's temperament. I just want to mention that we have a same TCI available for children and adolescents ranging between 7 to 14 years. So sometimes there are tests which are available for children, there are tests available for adults, but sometimes there is a gap where we don't have a specific tool for, let's say, for 16 to 18 years. So then we have to opt for something else which taps the same, so that we can achieve the goal. Then there are some diagnostic self-report questionnaires also. But most of the time when there is a referral for diagnostic instrument, do not depend only on self-report. There has to be a battery of tests, and we reach to if there is a corresponding findings, then we are more at ease to report that this person is suffering from this particular diagnosis. Otherwise, one needs to take into account the past history and the current symptoms before one makes the impression. MMPI is one of the earlier ones which we used to use for making a diagnostic diagnosis. However, it is very, very long. So now we are using more often MCMI-3, which again has 175 items. So it's long. And I would suggest that, but there is also limitation that the person should be able to read properly. So it comprises of 28 scales, 24 clinical scales, out of which 14 are based on axis 2 disorders and 10 scales based on axis 1 disorder of DSM-4. It has the advantage of this scale is it has modified indices which indicate that if the person is responding, giving distortions in their responses, or he is just casually putting a tick mark or cross. So there is an Indian adaptation in personality scale of MMPI, which is MPQ, comprising of 10 scales and also a K scale, which is a lie, which is a validity scale. But we often, while making, if there is a case for differential diagnosis, we often depend on the projective test, that is Rorschach, because it gives us more information regarding personality as well as the other psychopathology. So coming to projective, I'm sure all of you are familiar with this term based on psychodynamic principles, that whatever in an unambiguous stimulus, the person tends to give responses which reflect his own personality, attitude, self-concept. So this projection is used in interpretation. So to sum it up, I can say that personality scales are objective tests. Rorschach is totally projective, and TAT some way semi-projective, and sentence completion is semi-projective. Coming to sentence completion test, we often use it. It has student version also, adolescent version also, and often gives us personality analysis, clinical application, attitude of a person, achievement, motivation. comprises of 60 items, and you can see the scale that the area which it is tapping, one can make. That's why we say it's partial, it's sentence, it's semi-structured. Like for example, when I feel that the 8th item, I feel that a real friend, so it's tapping about the friend, the attitude toward a friend. Or my mother is, so it's tapping something about the mother, but how his response is going to be scored, that is ambiguous to the person who is filling up the form. So there are 4 major areas which it taps: family, sex, interpersonal relationships, self-concept. I'll give you an example. The different items are there for tapping the area on father. And one can see the different kind of responses that has been, how the sentence has been completed. Based on this, one can summarize that the person is feeling towards his father in terms as extreme hostility, and there is contempt or overt death wishes. So how we interpret that there are items pertaining to mother, father, family unit, and to what level, whether he rejects completely or there is partial acceptance or there is positive attitude. So we make the interpretation towards different 8 themes, whether friends, other people, supervisor, colleagues. So there are different areas how we can interpret. Then there is again another totally unstructured tool, which is draw. We use it for screening purpose, building up rapport. There are some unstructured tests where we use them for building rapport, especially with children. Sometimes the children or adolescents or even adults also are not cooperative, or they are wanting to hide, especially in the MLC cases. So we often try to build the rapport by giving these tests where the person definitely cannot understand how he can interpret. This is just a sample to show. This was a drawing made by a 16-year-old adolescent girl who was suffering from anorexia nervosa. Coming to thematic apperception test, we often call it TAT, originally developed by Murray in 1938. He developed a list of 28 needs, 24 possible forces known as press, and gave the concept of thema. So originally these cards were, I'm sure you must be familiar with that. There are 31 cards, out of which you can see that some of the cards are totally for males, some of the cards are for females, and some are common. And there are themes in each card. So out of 31 cards, we have 20 themes. So there are themes which are being repeated in different cards. Although they have to be presented in sequential order, and all the cards should be presented, but sometimes from time perspective, the patient cooperation perspective, and what is the goal of the referral. In day-to-day clinical settings, sometimes we often pick the cards, the areas which we want to assess. Like for example, one is very clear that we have already done some of the testing, and now we want to tap what is going on between father and child. So we give only father cards, the cards which are dealing with interpersonal relationships. We have an Indian modification of these cards where only the primary changes are of faces and dresses. The stimulus, the value of the original card has been retained. This shows the picture of the subject can interpret as father and son, or maybe uncle or teacher. So it tells us who is the ideal figure for the child whom he looks forward to. There are different ways of scoring, although it's some ways subjective, but so there are different ways of scoring. It can be objective, it can be content analysis, it can be theme. Depending on our need, we decide how to score and interpret. So there was the scoring given by Murray. You can see then the scoring has been given by Balak. Again, the same theme, hero, needs of the hero, how the environment is conceived. These are some of the basic themes which underline, irrespective of who has given the scoring system. And then there is one Indian also a scoring system given by Mehrotra. There is, for children also, we have CAT, Children A Perception Test, which using animal figures, and the subject, again similar to TAT, is supposed to make stories, like in films, is supposed to write which has a beginning, a middle, and an end. So what is happening, what was the past, what is future? You complete the story and you understand what was there a trauma in the child life, or whether he is too pessimistic, or there is depression underlying the theme, if the ideas are being jumped. So you, in fact, sometimes when there is no possibility of doing a self-report assessment, whether the person is illiterate or not able to read properly, or is too impatient, sometimes we do ask him to make one story or two story, and we see, are there any flight of ideas, or how he is jumping to conclusions, or if there is. So the thought disorder also comes very nicely in the stories. So different, they, in the clinical setting, sometimes we use different tests for different purpose. Now coming to the famous Rorschach ink blot test, comprising of 10 cards, 5 chromatic, that is 5 colored, and 5 achromatic. We have different 7 scoring systems. Over the time, a different system came up, one after another, everyone having different strengths and weaknesses. In India, we use Clover, Beck, and now the recent being Exner. Though not all the educational academic institutions have opted for Exner, it has an advantage of being quantitative in nature, but some of the strengths are people still prefer to use Clover. The basic essence remains the same. We identify what are the areas being tapped. The pictures are shown like this one. The subject is supposed to tell what he's seeing on the card and how much location he is using, what gives him the feel that this is bad, and whether it is color or shading, or he's moving like he's flying, and what is the content. Is it human, is it animal, or it's an animation kind of a thing, or anatomy. Like, for example, the medical students gave a lot of anatomy responses. So one response, it's subjective in the way that one cannot really pinpoint that, okay, a person who is illiterate or who is from a different non-medical background, if he's talking about many of the responses in terms of X-rays and all, then we may consider it as pathognomic. But if an MBBS student is talking about X-rays and all, then we do not say that it is pathognomic so much. So we must take into consideration while interpreting the kind of background the person is coming from and what kind of tests, what kind of responses he is giving. There are special indices also in when one is scoring through Exner system. And in Clover also there are various indicators. Like, for example, an organic person would be giving less than 10 responses. Or in the 10 cards, barely he might be rejecting some of the cards that I can't think anything. So he may not talk about any color. There may be a lot of perseveration that he is giving same response over the cards. There is he may be taking a lot of time in responding. So one tends to see how he is using the card and then interpret and score it. So despite being unstructured, there is a lot of objectivity also, and over the different raters, if they are skilled, they would be arriving to the same conclusion. That way it is standardized. Now coming to intelligence testing, which is, I'm sure you are more frequently using or seeing it. We start the IQ talk. The IQ concept started with Binet and Simon in 1905, and initially it was being talked in terms of mental age divided by chronological age into 100, but it was seen that over the age, as the child grows, it's not does not proportional to chronological age. So Another person who is very important in the area of IQ testing is Weschler, and who came up with the statistical criteria. He, on the normal probability curve, the test scores were standardized, and we talk about no longer in terms of ratio IQ, we talk in terms of deviation from the mean. So mean is taken as 100 and STS 15, and the scores are derived from the norms developed. So over the time, even Weschler has undergone revisions, and the latest, so it's Weschler adults intelligence scale for adult, we have for children, and we have series of revisions, one WAIS 1, 2, 3, 4, and recent being WAIS 4. In India, the WAIS earlier version was, we have an Indian adaptation called as Mallin's Intelligence Scale for Indian Children. However, the norms are very old. And the latest being, we have WAIS 4, the adaptation has been done. But unfortunately, the norms have been derived from children who are studying in public schools. So in a clinical setting where we have, especially in the government academic institutions where the population is coming from lower lower middle families, we find that the norms are, there is an error one gets from the IQ scores. So we still are, one knows that one should not be using the older norms, but we are still struggling with the new norms. There was some of the tests are totally performance based, and WAPIS, which was again an Indian adaptation of performance subtest of Weschler's adult intelligence scale. However, though we no longer use it, but was found to be very useful in the illiterate population. Mallin has the advantage among children as it has verbal as well as performance subtests, but can be used till 16 years only. And WISC, which is a recent WISC 4, it can be used till 17, 18 years. So that way, and the adult can start we can use adult scales from 20 years. So there was a gap between 16 to 20 years where we can just rely on Bhatia battery. To just give you an idea, WISC comprises of 11 subtests, 6 verbal and 5 performance. Information like how many years you have. The items increase in the level of difficulty level, and starting from very basic, and we see if one can judge that the child is not too low, one can start from, let's say, 3rd, 4th item. In comprehension, it gives an understanding about the knowledge of social appropriateness. Like, for example, if you get hurt, what will you do? Then simple arithmetic, if I break this pencil in half, how many pieces there would be? Analogy like lemon is sour, but the sugar is. Or similarity like, what is the similarity? Like you would be doing in MSc, mental status examination, that the difference and similarity between, let's say, orange and ball. So here we use there is a standardized how many items to be asked, and one can convert it into IQ based on the norms. Then we have vocabulary test based on each age. One knows that how much should the child be having the vocabulary. So like cycle, shoe, excuse me. Then digit span, I'm sure you would be familiar with this. It's digit span forward and backward, where he's supposed to repeat you in the same sequential order and reverse when it is backward. So coming to the performance test, you can see that the subject is required to identify what is missing. Here the nail is missing, here one of the comb is incomplete. So in block design, there are blocks, and he has to make the block similar to the pattern that we have given him. And then there is object assembly, where he has to assemble the objects placed in front of him in a random order. Then there is coding, where there are symbols paired with the numbers, and he has to, looking at this at B, he has to as fast as possible, he has to pair the right symbols, and then one checks the errors and how much time he took, how much he could complete. And then lastly, there is maze. So without picking it up, he has to trace through the maze and reach the end point. So in MISIC, we derive the full IQ score, verbal IQ and performance IQ. But WAIS 4 has an advantage that it eliminates dual IQ. It measures in terms of processing speed, working memory, etc. And there is improved psychometric properties. So it has 10 core subtests: verbal comprehension, perceptual reasoning, working memory, and processing speed. Now, as we all know that when one is talking about mental retardation, or when one is talking about patients with dementia, we also want to identify the social adaptability. So we have two important scales for it, which are based on the like how much, at what age the person should be able to do. And one is Vineland Social Maturity Scale, and it taps these different areas. We have Indian adaptation of same, but again, it's an old one. It, like, for example, one expects that the child should be trained at 2.5 years for toilet training, or by around 9-10, he should be able to have his bath, or he should be able to communicate at what age properly. So these, based on the skills he has, we identify his basal age, and then derive the social quotient. The recent Vineland Adaptive Behavior Scale, again, it has revisions 1, 2, 3, and it has an advantage of, it has interview form, parent form, and teacher form. And we can go in more depth in each of the communication. Like, for example, in communication, we can assess him on receptive, expressive, and written subdomains. So this is more detailed. The disadvantage is it takes a little longer time, but the advantage is that if you want to really go in depth when the child is very small, or when he is where one wants to do rehabilitation, then it's a good scale to be used. Some of the tests we use are screening, like Gesell's development screening tool, where one asks the child to just draw plus or circle, and we know that, okay, if he is able to draw that, it is not based on education or exposure, but one has to take care that his muscles, there is no psychomotor disability, so one can give that screening tool. Then there is Vinay Kama test, which is ideal for assessing mental retardation. And it gives us again a ratio IQ. It's available in English, Kannada, and Marathi. You can see the various abilities which can be tapped. But again, it's an old test with older norms. And recently we are, Dr. Rupesh from NIMHANS has done a lot of work on what extent these earlier tests, they are applicable in today's setting. Then another performance test we use very frequently is Bhatia performance. Some of the tests you have already seen: block design, pattern drawing, picture construction. This you can see the box. This is the pass along test. Again, he has to, based on the pictures, he has to make the design without. These are the pictures of the pass along, and he has to make the same picture on the blocks without picking up the blocks. Then this is object assembly, and this is pattern drawing. So Sanguine form board test. This is a performance test, but it's a speed test. So one has to be careful. If a child is ADHD, you may not get the right IQ, but it's very useful in illiterate population. He has to pick the blocks and places in these spaces. And there are 3 trials given. The blocks are placed outside in a particular order, and there are norms available, and which gives us a mental age. Then there is another very good performance test, Raven's progressive matrices, available for children in colored progressive matrices, for adult standard progressive matrices, and for people suspected to have high IQ, we use advanced progressive matrices. It gives a G factor IQ, that is global capacity, and it's a culture-free test and is useful where verbal instructions cannot be given or the child cannot speak. So this is just to show one set. It has around 12 sets for standard progressive matrices. Each level of difficulty rises with the increase in items. So we use IQ for different purpose. It forms part of neuropsychological assessment. When SLD is suspected, again IQ forms the basis to go further. When one is suspecting attention deficit, then again one also assesses IQ so that one knows how much he is being affected by hyperactivity and how much is the ability. So that when the parents come with academic problems, one needs to understand the potential. Even the patients with having injury, brain injury, IQ is one of the foremost step when one goes into further neurocognitive assessment. When sometimes we do not directly need to go for MRI CT scan, especially when one wants to know the functioning, to what extent it is impaired. And even the neurologist also, after doing MRI or CT scans, when one talks about rehabilitation, one needs to stick to neuropsychological assessment. The purpose for neuropsychological testing can be varied. One wants to know the strengths, one wants to know the weakness, one wants to go for rehab, one wants to identify the lesion in which area it is located, or it is diffused, or for the outcome. So in the Western setting, I'm sure you are all familiar with the term Halstead-Rethan neuropsychological battery and Luria-Nebraska neuropsychological battery. The tests are why we are talking about battery, because no single test can give us a one. Let's say, for example, if I do just one test for IQ, I should not be saying that this is the IQ of the person, because the ability is not just one area. When we talk about IQ, it's a global capacity. So there should be multiple tests to tap different areas, and one tends to identify, especially in the clinical setting, the report should be mentioned in terms of which are the deficit areas and which are the strengths, which are not affected by the illness. So one should be doing a battery of tests, whether it is a standardized battery or one can pick up various different tests and do one's own comprehensive testing. One can take a fixed approach or a flexible approach. We do have Indian adaptation of Halstead, which is an enhanced neuropsychological battery. Here again, we have a separate battery for older people, and different by and another by children and for adults. People from NIMHANS, Dr. Shobhani Rao, Dr. Mukundan, have worked for development of this battery, and we have norms available. Then AIMS neuropsychological battery, which is based on Luria-Nebraska battery. But the disadvantage is that it's too long. It takes almost 2.5 hours. But the strength is, it is very good for giving us a very, very detailed information with on each domain as well as the lobes. Then we have PGI battery for brain dysfunction, which talks about area about perception, or which then talks about memory, then cognition. So it's an assortment of different tests, and there is a score. There are norms available, and one can derive the level of dysfunction from this battery. The level of dysfunction. It comes in useful when one is talking about disability. So when one is talking about intelligence, one also needs to, which forms a part of cognition. So it's an umbrella term which comprises of attention, perception, concentration, memory. So depending on what we are interested in, we pick up tests. For example, for attention, we have different tests, and then we should be aware that what are we interested in: focused attention, sustained, or divided, or all. So depending on that, we pick. And there are different, like in I talked about MISIC or Wechsler, WAIS and WISC. We have tests of digit span. So that also gives us attention score. Then this is letter cancellation test. Then in terms of perception, visual motor dysfunction, Bender visual motor gestalt test is very frequently used as one of the first tests because it helps us to build rapport. The person who is even illiterate, it is a good screening test for organicity. There are two ways of scoring it. One is by Hayne and then another is by Pascal. Pascal is more detailed one. In younger children, it also gives us a sort of an IQ because it tells us how much the child is able to draw. But giving this test to a person with, let's say, muscular dystrophy and or cerebral palsy, and then or he has visual deficits and is not wearing specs, then the scoring and the interpretation would be wrong. So one should be vigilant what test to use and what are the strengths of the person you are administering the test on. So these are the BVMG cards, and this is how the patient draws. Then comes the memory. I'm sure you are aware of the various aspects of memory, the registration, recall, immediate recall, recent, and long term. So different aspects have been tapped by different tests. Most common, I'm going by different tests because of the paucity of time. These are part of NIMHANS battery. These are most of the common tests that we use in the clinical setting. So this is verbal NBAC test. And we have NIMHANS, in NIMHANS battery, we have the norms available. This is how we give the consonants, and he has to just repeat it consecutively. You can see the consonants, and in the two back, he has to tap when the consonant is repeated after another consonant. So one gives one back and two back and then identifies the errors. We have PGI memory scale, which is Indian adaptation of Wechsler memory scale. It has different subtests like attention, recent memory, recall, recognition. It takes around 20 minutes to complete it. The advantage of using PGI memory scale is we have Indian norms for different type of illiterate or literate population. Then we have animal naming test, which is very simple, that you have to name any name of the animal in 1 minute. So in 1 minute, you see how many words he can use, or we say that you can, but in this, the nouns are not used. Then coming to executive functions. So again, what we are interested in, if we are interested in understanding the whole spectrum of executive functioning, which is higher order functioning, then we use all these tests: Tower of London, Stroop test, Wisconsin card sorting test, which gives a very comprehensive result. This Tower of London test, as you can see, comprises of this board, and the person has to, one can see this goal. He has to, without moving, he has to move these and remember this, how he has to put them in order. Then Wisconsin card sorting test, it has different cards, different designs, different colors, and he has to understand what he's supposed to do. There are no specific instructions, he just has to match them. and only Q which is given is whether it is right or wrong. So he has to understand whenever it's wrong, what is the underlying principle involved in the matching. So this is how the scoring sheet looks like. It's a complicated scoring and needs some training to do it. Otherwise, the interpretation is wrong. So this involves set shifting. We are used to doing in one way and we have to shift the principle, which is difficult for the psychotic patients or patients having organicity. So perseveration is there. Then Stroop color and word test. Here there are 3 tables. One, he has to read the words. Then they are written in black. He has to read the colors again in black. Then where there are different colors, he has to name them, the colors. Then there are different, he has to read the whatever is written, and accordingly the errors, one again he is seen, the executive functioning is assessed. Then for verbal memory, this is the association learning test where the different words are given and different trials are given. He has read out the same list again and seen how many errors he make over the 5 trials. Then parietal, so one can see the different lobes. One has identified which tests would be giving an idea about these functions of the parietal lobe or frontal lobe. This is relatively a simple test, but difficult to score, where even an illiterate person can also draw. He has to make these lines and it is scored accordingly. So in the end, I would say that psychological testing is it can be really an asset if there is a proper referral. If the person who is doing the testing knows what the clinician is looking for, it's not a technician job. So one has to, usually a clinician makes an error by just writing that please do Rorschach. One would be more interested in knowing that what you are looking for, whether it is the psychopathology or whether you are looking for personality, because same test can be used in different ways and different interpretation can be done. Then if one gives some background, what a clinician has judged, then it helps. There is a coordination between the person who is doing the psychological assessment and what the clinician wants. So at the time of, it's a collaborative formulation for diagnosis and for treatment. And the test can also help in rapport building. Sometimes you have a referral from a child or an adult who had a trauma. He is not willing to, pen down words or write anything or read anything. Then unstructured test can be a good way for building rapport. Then sometimes you get a referral from a person who speaks another language, and where you have to depend on non-verbal tests to get an idea about the understanding of the subject. So one can refer for psychological assessment for when one wants to make a diagnosis, when one wants to have some treatment or decisions, or when one wants to have the fitness, whether the person is fit to return to or why the treatment is not working. So making a right referral is very important, and understanding the report is important because it helps to be more precise for the tester, and for the report also can be more specific to what the clinician wants. Thank you. So if there are any questions, I can.
Good afternoon, madam. Congratulations for a very nice presentation and covering so many tests in the short period of span. appreciable, and you have covered almost all the tests. I have one or two questions related to testing, especially we do come across the patients of personality disorders. At times, we are quite clear clinically that the patient is having borderline personality disorder. And at times, there is some confusion that we are trying to fit into a cluster B or cluster C. So in Indian settings, do we have any specific test to diagnose for these personality disorder patients? This is my first question. And we do come across juvenile offenders in our institution, and where court direct us to specify the mental age of the patient, especially 16 to 18 years of the age group. Nowadays, if they are doing some crime and they are fitting in a chronological age is 16 to 18, they ask us whether the person is having mentally age of an adult, so that they can direct a decision for the punishment of these juvenile offenders. These two questions, please.
Thank you for the questions. They are very, very important. And actually, because of paucity of time, I decided I did not cover about IPD personality disorder per se. Because I thought that as a psychiatrist, one would be familiar with IPDE. That is WHO's system of classifying personality disorders. It gives a very comprehensive. Each of the personality disorder is it is based on it's interview based from the patient, from the family, and then one corroborates, one takes into account the whole history, all the past events. And like in antisocial or substance use disorders, where personality disorder is always a comorbidity, there are different questions where one can one can see the inconsistencies, and one can tap that the patient is lying or is manipulating. Then from corroborates with the family members that what were the various situations in the past where they found that he has been manipulating them. It's a very, although it takes around 2 hours to do a comprehensive evaluation, but when you are in doubt, especially when it is, there is a referral, I would recommend IPDE. Don't use the screening scale, which can be erroneous. Go in for a detailed IPD, which would be conducted in not in one session, but at least 2 to 3 sessions. And it gives us whether the person is actually PD or or there is just a trait. Then we do have, I talked about MCMI, but at the same time, my clinical experience, like we do it MCMI, but we do not give our just findings on MCMI only. So taking the clinical interview is most important when one is talking about personality disorders. So no one test should be enough, and one needs to base one's impression here. Clinical judgment definitely is more important, but clinical interview, then the MCMI and IPD, I think this gives us a robust way of reaching to a conclusion. That is, I think, my answer to your first question.
Thank you.
Coming to the second question regarding juvenile, yes, we often, when I was in Chandigarh, we often used to come around adolescent or even mentally retarded, where there was no informant coming from orphanage or, police has apprehended, where there is no person who can inform about the age. Then one is that they also calculate the bone age. Second is, if the person is not able to tell, then CPM, colored progressive matrices, although it's meant for children, but when is not sure about the age of the person, he is adolescent or he is a child, there is a conversion table available in colored progressive matrices. Depending on the raw score, one can convert to an adult, and then one can reach to an IQ without even knowing the age of the person. Then one can also use GDT. So like I said, that no one test would be sufficient for arriving to a conclusion. One can ask the person to draw the various symbols, square, cross, triangle, rhombus, and there is a standard way of checking that what is the mental age. Then one can also do, if possible, VSMS or VAPS. So the social adaptive functioning can also be tapped. And then one can calculate the mean of all these areas, and then one can assess that whether the mental age across the tests you are arriving is similar or not. That is one way of going about it when you do not know the chronological age. If at times you are not sure about the exact age, like whether it is 17 or 18, but generally you have an idea, then again one can go in for Bhatia battery. So these are, otherwise one is dependent on chronological age, definitely. See, it depends whether you are aware about the educational background or you are aware about, so whatever the information is, depending on that, one decides upon the test. And lesser the information, you rely more on the battery of tests, and you see that across the test, whether the mental age is corresponding to the other test also is not. You do not calculate the mean, but at least you can check the mental age across the tests.
Thank you.
And in these cases, I would also like to add, observation is very important during the session. You know, when one is, many times the family members want to hide the information, want to get the benefit of saying that he is juvenile. Excuse me, please. In such cases, like for example, they are saying that he is mentally retarded. So you ask nobody should be there when you are observing the child or asking the child to do the testing. And then you make the child do some of the things yourself, like washing hands. Excuse me, please. Or depending on the age, you know, sometimes the parents come, like he can do it or he cannot do it. So you can check if possible. Like I remember asking the child took the child to the corridor and make him climb the stairs. You want to check yourself. So it's very important that do not think that in one session only we will be able to conclude the testing. There is another thing which I have not talked about is SLD. Nowadays, one is talking about disability certification for students, and many times there is malingering. So when one relies on specific learning disorder battery, which is by name Enhanced SLD battery, one should also take into account the notebooks that he has been doing in the previous year. Then one can rule out the malingering, because he may do it, he can, when you are giving him the task, he may show that he is not able to do or he is doing it incorrectly. But when you see the past year records and you can see whether, sometimes parents say, "Oh, to likhta hi nahi tha." He would not write at all. But if you insist that we cannot give the certificate like that, then malingering comes out. You are able to identify and it helps. So one should be a little bit cautious when one is giving the disability certificates in such cases.
Thank you, ma'am. Are there any other questions from audience? Thank you so much, Rachna ma'am, for such an informative lecture. It was very beneficial for all of us. Thanks for giving your valuable time.
Thank you.
So, unfortunately, due to some reason, the debate which was supposed to be now, has been cancelled. So we all end this program of PG development here and we all proceed for lunch. Thank you once again and hopefully we'll meet again. Thank you.
Recording stopped.